there are a couple of audience segments that we have as a mandate to regularly focus on. Women, of course, is chief amongst those, but also the youth, because of a couple of reasons. One is slightly selfish, that I do a lot of work in terms of my teaching with middle high school students, college students, but also because from a mental health standpoint, from the perspective of breaking taboo and stigma, I think a lot of people might agree that it makes more sense to focus on the younger demographic rather than trying to change very, very set perceptions and opinions of an older generation. Having said that, when it comes to the youth, we tend to have an extremely myopic view in that we see them as just one segment, not perhaps realizing that within the youth, there are so many layers, so many nuances. There are young people that belong to different communities, different financial strata, and they all come with very, very unique sets of challenges, lives, distress, and therefore the ways that one has to approach them in terms of their mental health, both in terms of analyzing them and in terms of guiding and supporting them. I'm very lucky that the individual joining us today is herself a young psychologist and somebody who has worked with various different segments within the youth already in her young career, and will be able to therefore share insights that will be very different from the way we tend to simplistically view and interpret the youth. Yashodhara Kundra is a highly qualified, very well educated therapist and is joining us all the way from London. I'm extremely grateful for her time and effort, and despite her busy schedule and the time difference, not to mention. So, Yashodhara, thank you very much. Welcome.
Thank you for having me. And I'm really excited to actually speak about this topic because podcasts are one thing that do reach a lot of young people. So this is a good platform to talk about it.
Wonderful. We are calling the session The Young and Restless Working with Youth. This is Talk Therapy, brought to you by Driveway Devi, and I'm Karthik on behalf of Driveway Devi. Now, Yashodhara, before we get into the nitty gritty, I would love for you, for the benefit of our listeners and watchers, to outline briefly a little bit about your current work.
So I was born and brought up in Calcutta. And when I was really little, I had two dream careers. One of them was to be a writer on Grey's Anatomy because I loved all the drama and the stories and the cases that came in all the time. The second was to be a psychologist. It's because I come from a family background where I think I noticed that a lot of really large problems would become very small if we just talked about them and shared them. It's like we would take bits out of the large circle and then it would maybe become smaller. So that's what I did. I studied in the US for my undergrad because I wanted to learn a bunch of subjects together. At that point, when I was going to college, it wasn't possible for me to do that in India. So I went for that scholarship. I tried my best and I ended up majoring in psychology and creative writing. But along with that, I studied a lot of philosophy, I studied logic, I studied other subjects like even biology, which helped me understand human beings better because ultimately my goal was to be a therapist, be a psychologist. Since then, I've completed a master's degree in counseling, which is the minimum you need to become a therapist. Um, and I've been working with children and young people in a counseling capacity since then in the UK. Now, this has been majorly across schools because that's where I've been able to get access to a lot of young people in the same place without having to navigate the issues of getting them into the counseling room. Um, yeah, and just to clarify, because I have my qualifications across places. In India, my title would be counseling psychologist because you need a master's degree and work experience. However, in the UK, I'm an integrative therapist. A counseling psychologist would have a doctorate, which I am working towards now. That's my next goal. But the work that I'm doing is the same in both the places.
Got it. Well, at the cost of a little bit of an aside, a quick aside, I'm very glad that you picked psychology over your other desire to be writing Grey's Anatomy or something of that ilk, because I think you're doing extremely valuable work. And the funny thing about Grey's Anatomy, because I've had some experience in the media and television and film myself, is that it was always extremely funny that an overwhelming majority of the action, pun intended, mind you, took place in elevators.
It absolutely did. It was my introduction to elevator pitches.
Okay, wonderful. Great. So now, by virtue of working with young people at schools in the UK, I also know, like you shared with me earlier, that there is a very specific target audience that you had sort of the opportunity to interact with a lot. Tell us a little bit about that particular segment of people.
Okay, so when I first came into counseling young people in the UK, the only experience I had under my belt was working with mostly like upper middle class and quite educated, privileged teenagers in India. So when I came in here, I wasn't sure what to expect because most of the schools that do contract counselors are public schools. And I began in Birmingham, where I worked in areas like Walsall, and then even in the Birmingham city center, where there was a lot of schools where there was where most of the population was ethnic minorities.
Mhm.
Um, so I worked with a lot of immigrant populations, second gen immigrants, a lot of young people who were put in foster care. So here we call that group looked after children. So children who are known to social care, which means children who have dealt with professionals like social workers and family support workers their whole life, police probably. So they have a lot of exposure to the system. So I would say that these were students and clients who already understood what systemic injustice looks like. And when they came into counseling, it was quite evident that the work was not to grow immediately, but was to bring them up to the baseline.
Mhm.
You know? So yeah, that's majorly the group I've worked with. It's been quite a range. Some young people have come in with maybe refusing to come to school. So school refusal, being sick a lot, that's a big one. Exam stress and pressure. These are the students that are able to really like internalize the systemic distress, where they are thinking about perfectionism, they're thinking about moving ahead in life, getting out of there. Whereas the other end of the spectrum has been students who've been quote unquote naughty in some way.
Mm.
It could be something as small as being caught with a vape,
Mm.
or it could be something bigger than that, like they've been a part of some violence,
Mm.
or they've been recruited into a local gang.
Sure.
So yeah, it's been a range of clients that I've seen in the UK so far.
I'm going to delve into this a lot deeper, but before that, a question pops into my mind, which is sort of off script, but it's come up in context, and I think it's important.
Mm,
Uh, so in India, and I'm sure you're aware of this,
mm,
we are, although again, India itself is so vast and diverse, it's really quite unfair to generalize, but
mm,
we are a lot of, let's say, a lot of cities are
mm,
in this stage where very recently it's sort of become a thing that a school, a high school, a middle school would have a mental health professional or resource sort of on the payroll.
mm,
It wasn't so until fairly recently.
mm,
And even now, I have on good authority that this one single resource that is oftentimes part of the campus or the school
mm,
is so limited in his or her efficacy despite their absolute sincerest efforts by sheer virtue of the skewed ratio, because there's one resource and there could be upwards of 1,000, 2,000, 3,000 pupils in that particular school. Also, I know that invariably in India, the mental health professional is also very conveniently used to actually teach the psychology subject to senior school, and therefore, in any case, is spread very, very thin.
mm,
The reason I'm sharing this complicated context is that how is it in the UK when you say that these are the kinds of schools that sort of outsource services from people such as yourself? What is that ratio like? And do you feel that there is a genuine possibility of being effective and making a difference?
So, yes, you're absolutely right about the Indian context here. And my experience so far has been that the schools in India that do have a mental health professional, usually this professional ends up dealing mostly with students who have special education needs.
Yes.
That's only very recently, I guess, been recognized as something that needs help, or that the school has a responsibility to help. So, for
Right, but
example,
also, and at the cost of interrupting you, and I'm not trying to sort of sit here and pass judgment on any country or schooling system, but that also has happened largely because now it's been mandated that
yeah.
quote unquote regular schools must have a certain intake of special children, special
Mhm.
needs children.
Yeah. Yeah. So, yeah, I guess that mental health professional in there is struggling to make a very large impact in numbers, because just there isn't enough time. There aren't enough hours in the day. Um, I think in the UK, it is quite similar for that one professional, because to give you exact numbers, in Birmingham, I was in a school that was large. It was about one class. So let's say it's a year group, basically. So let's say it's year group 6. There's um, sections within each year group where there might be anywhere between like 20 to even like 35, 40 students in each section of
Mm-hmm.
that. So yeah,
So,
large
so
school.
not vastly different from the situation here.
Not at all. Similarly, with the school I worked with recently, which was in London, it was even larger. There was about maybe 2,000 something, 1,800, 2,000 students
Mm-hmm.
at the school. And there was 3 counselors. So I was full time, and there was 2 other mental health professionals or counselors on staff who were part time. So I think collectively we managed to see about 30, 30 students in one section. So we do sessions maybe from 6 sessions. We contract for 6 sessions, maximum 12 sessions. So it's not like you're seeing new people every day. Um, so I would say that what's different, I guess, is that there's still trainee counselors on staff,
Mm-hmm.
some schools. So this is not good for the mental health professionals because it's free labor. A lot of trainee counselors they have to go into a
Right, right.
school or a placement setting and provide counseling or therapy for free.
Hmm.
And they get the hours so that
Sure.
they can graduate. So that's one way that people are getting more support. And then I think that in UK schools, I've noticed that the expectations, so like you said, the mandation, um, it's more broken down into different responsibilities. So there are TAs or teaching assistants.
Right.
There's specific teaching assistants that are specialists for students with social and emotional mental health needs. Then there's also other support staff like family liaison
Hmm.
workers.
Hmm. Correct.
There's
So there's an entire system and an
yeah,
infrastructure.
exactly. There's more of a like system, like you said, around the child, and the mental health professional then is free to work just with mental health
Correct, correct.
instead of having to deal with learning needs and how to be able know how to get them free meals and how
Hmm.
to maintain their well-being with
Hmm.
their family.
Hmm.
So I think just because they have less responsibility in that sense,
Hmm.
they're able to give more time to
Also,
just
to quickly clarify, when you say 6 sessions or 12 sessions, is that with a particular individual?
yes. So I guess here I'd have to give you a little, I guess, a little side note maybe about the main difference between counseling and therapy. I know that we use it interchangeably, and I
Hmm.
call myself counselor and therapist interchangeably, but they are different.
Hmm.
Um, in essence, they are different, and the goals are different for
Hmm.
both. I call myself a therapist because I've trained to be able to do long-term work as well as short-term work
Hmm.
with a
Hmm.
client. So with children in schools, it's mostly counseling
Hmm.
because logistically speaking, it's not feasible for a school to continue paying a professional to work with one student over 6 years.
Sure,
They
absolutely.
want to be able to, keep the ball rolling, and they want the professional to see many students.
Yeah.
So now counseling is short-term work. Now short-term could mean anywhere between, usually the bottom line is 6 sessions because you
Hmm.
need to have a beginning, middle, and end. But it could go up to 12 sessions. In some cases that are more complex, 16 sessions. But it's rare for it to go beyond that.
Hmm.
If it
And so, in
does,
the grand scheme of things, that's still pretty finite.
that is because then what happens in counseling though is that because it's limited in time, it's ethically not, or ethically speaking, counselors don't take on any really complex long-term work.
Hmm.
So even if they've taken on a student with a lot of complex needs, they might have to set goals with the client in a way that there's a shared understanding that, hey, we might be able to go into academic pressure and perfectionism and self-esteem a little bit in here. But counseling, the scope of counseling is just that. We
Yeah.
will not be able to go into, let's say, like reparenting for you, or we don't want to open up a box that we can't close within
Correct.
the time that we have. And therapy is different because therapy doesn't usually have a time limit.
Sure.
The therapy is usually more private. People pay for it out of pocket fully. For each session, a good price, and it goes on for as long as you want it to, when till you usually or your therapist feels like the work is done. So yeah, because it's counseling and it's short term, it has some limitations in that sense.
And this is probably tricky to answer, but these 6 to 12 sessions, typically speaking, on average, take
Hmm.
place over how much duration of time? Is it uh, a month, 6 months?
So my experience, or what I guess maybe I'm a little bit more idealistic because I've only in the recent few years qualified and started working with people in schools, but I try to keep it as consistent as possible. So a weekly session, um, it would be nice if it could be the same session each week for consistency.
So you
But
try and approach it like therapy instinctively.
yes, and counseling is not meant to be, in fact, there's I guess, a little bit of a myth that counseling is when you feel really bad, you have someone to talk to, but that's not it.
Hmm.
Counseling needs to be and has to be very boundaried and very time sensitive and consistent for it to work.
Hmm. Hmm.
If you were to be able to call me or message me every time you were feeling distressed, then I'm only teaching you to be dependent on me. I'm not helping you learn how to regulate your own emotions. So that's why counseling still works like therapy when it comes to these things. You still have a timetable. You still come to me when it's our time to meet. If you're feeling shit outside of that, then you need to use what we've talked in our sessions about and
Hmm.
manage your emotions or
Hmm.
use
Hmm.
resources that I've given you outside of it. But yeah, it does work like therapy when it comes to the consistency. And it goes on over those 6 weeks, and they're usually continuous, 6 or 12 weeks. But of course, there's school holidays in between, which we call like small endings. We use that as a way to model what a larger ending would be like.
Hmm. Hmm.
Yeah.
Would it be unfair to would it be sort of really presumptuous uh, and unfair to assume that
Mhm.
many individuals in this particular milieu, this ethnic minority, sort of not particularly financially stable, uh,
Mhm.
would be individuals who would have encountered sort of distress and trauma that would ideally require therapy intervention.
Mhm. Yes, of course. But therapy starts with counseling.
Hmm.
So maybe beyond the 7 week, 8 week mark, we've already moved from short-term counseling to long-term therapy. Um, and I guess therapy is something that you continue for a lifetime. It's just like going to the dentist, right?
Sure.
If I were to speak from a therapist perspective, of course I've had times when I can't afford it, for example, therapy for myself. So I take a break where I don't feel compassionate enough to be able to do it, when I don't have the time logistically.
Hmm.
So yes, there's many reasons to stop
Hmm.
and many reasons why it should go on. But I feel like with the correct interventions within counseling, towards the beginning, especially with how you build that rapport with each other, um, counseling work can be pretty therapeutic by the end of it. And if you start to end at the correct time, um, I think it's absolutely fine if you can provide maybe 16 weeks of consistent care to a young person who probably has never been able to name what they're feeling before, you know?
This is such a vast area, and I'm greedy to ask you lots of questions. With last few, and
Mm,
I'm sorry to draw the comparison again. It's only to provide a perspective.
mm,
Another big preoccupation of school therapists in India
mm,
is firefighting, because every other day there's some chaos and specific incident that takes place, and then
mm.
that therapist's time, effort, and attention goes into just managing that crisis situation. Does that
Mhm.
also tend to happen?
Yes, of course. I think firefighting is a part of the job, but one thing that I've realized, I think that's acceptable within the therapy community at least, is that we are very intentional about our boundaries when it comes to work. So we actually within our training, or if you talk to someone who's done a master's in counseling or therapy or psychotherapy, we actually learn how to manage these fires without losing ourselves in it.
Hmm.
um, at least it's a transferable skill that we pick up. So if I were to give you an example, right? So um, this would be in India or in the UK for me. If I'm in a session with a client, and they have disclosed self-harm in the session. So this young person has said that I have um, I have cut myself last night. I
Hmm.
have hurt myself quite bad. It's still bleeding, and I don't know what to do. And I'm dealing with this young person, and I'm working with them, and I'm writing a risk assessment with them, and I'm also, of course, responding to them and their pain. And at the same time, I have a student or a client who's meant to see me on a different day, but they have special education needs. So this student has ASD, and they don't remember sometimes when their session is, and they come start banging on the door. um I guess usually I should be or would be expected to deal with it, or make sure that everything is sorted. But I did have the authority to, and I did have these set rules with my co-workers or the school personnel that were in charge. So in the UK, they are called designated safeguarding leads. So these are people who are trained in handling these situations. I would take a moment, I would pause, and I would step out, and I would take this young person to the DSL and say that,
Hmm.
hey, I understand you're distressed. Here, you can have this. So I would give them a toy, for example, because I'm working with that age group.
Hmm.
And I would
Hmm.
say
Hmm.
that you need to give me some time. You understand our contract. I have a contract with all my clients that is very clear about what happens when I'm busy and you need me. What what happens if you come to me when we don't have a session? So they
Hmm.
expect it. And then I come back to it after I'm done with my session. Um, if there's a panic situation somewhere and I'm asked that, Yasho, this student is having a horrible time, they've locked themselves in the bathroom, can you help? I still draw a very gentle line there and saying, yes, I can help. I don't have anybody right now that I'm meant to see. Could you please bring the student here?
Hmm.
From the beginning, I set the expectation that I'm not about to go break down bathroom
Right.
doors,
Right.
because behavior management is not my job. It's
Hmm.
it's
Hmm.
therapy.
That's
And that's
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 that's so important because I don't know. I can't speak with any kind of authority here, but I suspect that a lot of this is absent here,
Mm-hmm.
and it makes so much sense. It may seem to some people touch insensitive, but it's just, I think it makes everyone's lives infinitely better. And it in fact enables the professional to
Mm-hmm.
be a lot more effective at what they're actually supposed to do.
Yeah. Yeah, I mean, a big part is to, if the students, it's a genuine like concern. If the students are seeing you as just another teacher, they're not they're not going to see you as a therapist.
Yep.
It's not possible for them to do that kind of code switching where they're opening up to you about their deep dark secrets at 9 a.m. and then at 11 a.m. you're banging on the door trying to get them out of the bathroom.
Okay, final two questions. We spoke about this. I think it's a very important facet of this entire thing, and we must bring it up.
Mhm.
Um, Not just in your case, in so many cases, it would happen that as a therapist, one's life is a certain way, and you occupy a certain world, and you have a certain world view,
Mhm.
which could be extremely removed from that or those of the people and individuals you are meeting as your clients, particularly when it comes to, again, ethnic minorities, children going to these kinds of schools. What are some of the things that what are some tools that you employed in order to sort of make yourself more understanding and empathetic of their distress, of those causes, of the worlds that they seem to inhabit, which may be completely sort of parallel lines to your own?
So basically, me being someone who doesn't know what life is like for them, how do I understand them and work with them?
Absolutely.
I think just how I would work with you, if you were to come in as a client of mine. Um, so here I'll give you
For
some
your sake,
context.
I don't wish that happens, but okay.
But here I'll give you a little background
Yeah.
again, maybe a little bit psych jargon, but not all kinds of counseling is the same.
Hmm.
Um, just like if you go to a psychiatrist with the same problem, they'll have a different view
Sure.
of what's happening to you. You go to a counselor who's trained in CBT, they'll have a different approach. You go to a counselor trained in a different modality, they
Yeah.
might have a different approach. I'm trained in something called person-centered therapy. And then along with that, I work with attachment therapy and something called interpersonal neurobiology, which is
Hmm.
quite new as a field.
Hmm.
But this is just a fancy way of saying that I am not the expert in the room.
Hmm.
Um, I don't go into a counseling room with any power over my client.
Hmm. Hmm.
So what person-centered therapy says is that the client knows best,
Hmm.
and we are in this together. Most of the work in these relationships is done collaboratively,
Okay.
and getting to know each other is also a collaborative process.
Hmm.
So I guess what I have done to be able to understand these young people is firstly remove all the frills and put myself in a little box with them with just a course. Maybe a not very psychological view here, but a personal view here is that sometimes it's just enough to try and remember what it was like to be a teenager myself,
Hmm.
to be 6 or to be 10 or to
Sure.
be 14.
Hmm.
And what are the stresses I felt?
Yeah.
What are the problems that I faced? What are the thoughts that went on in my head? In fact, towards the beginning, I went back and read all my diaries from when I was a young person, when I was 10, and writing about missing my mom, or 14 and worrying about girls bullying me because I don't want to put on a swimsuit. And I think that maybe the language is different, but the problems at the core remain the same and have helped me connect with these people.
Hmm. Hmm.
Yes, in the beginning, they're like, you're not going to understand. You look like you're from a different planet. I've seen the bag you have, I've seen the way you talk. Just with me, it's not, I'm not hiding anything, right? You
Yeah.
can just, as soon as I open my mouth, you can hear my accent. You can hear that I'm not from the UK. You can
Hmm.
see, I guess, the way my nails are painted and see pink is my favorite color. You know so much about me as soon as you see me as a client and as a teenager who's used to noticing these things. Um, and you immediately create distance. My job is to fill that gap with things that we can both relate to.
Hmm. Hmm.
Yeah. So I'd actually thought about this a bunch because you did share with me some things about this conversation. And I would say that some problems or some issues that are at the core of everything are, first would be academic pressure.
Hmm.
I think that that's been a constant, and even if it's not at the forefront of everything, or if it's not the core of everything, it does have a large impact on their day-to-day life. They're not coming to school, they're being bad in school, they're not studying. That usually gets them into the room. So academic pressure, which is very deeply tied to identity, I think, and self-worth. There's a lack of emotional vocabulary, and I would say that the other issue that I've noticed that has been similar with my upbringing in them, um, and I think it has nothing to even do with South Asian heritage, honestly.
Hmm.
I think
Hmm.
it's more about dysfunctional family systems. I would say intergenerational silence. I know we talk about the trauma a lot,
Hmm. Hmm.
but
Hmm.
there's this silence that comes with being in some kind of families where you don't talk about anything.
Absolutely.
That silence is worse um, than active um, denial sometimes of mental health problems. Um, so yeah, I mean, I would say that I managed to connect with them based on interests, maybe. So I use play therapy a lot and art therapy. So it could be listening to music that we like together, or just to talk about our differences, talk about, yeah, I'm older than you and I'm not from here. What is it that you can tell me about this place? How do I survive in London? How do you survive East London? Or I've spent, I think, time talking to a young boy about the gangs in his area because he was sent in for being affiliated or trying to get into one of them, trying to associate with them. And I think sometimes it's just about being curious and sort of nonchalant about, okay, that's what's happening. Let's talk about it.
Mm.
Um, and therapists don't self-disclose too much. It's a part of the process.
Mm.
But sometimes it's necessary, especially
Yeah.
when it's with younger people, because a major or let me say it like this: in-person centered therapy, you're meant to be congruent, which is a way of saying that you need to align with their values, but in a real way. So for me, a lot of the times, being able to connect comes with just being able to still have some sarcasm and humor in the room,
Mm.
to call them out sometimes, to
Yeah.
joke and
Yeah.
laugh.
Mhm.
Um, and that's helped quite a bit. Mhm.
Do you find that between genders, they come to you with very different kinds of issues?
Mm, I would say again, like, I really don't want to generalize, but from what I've noticed is in this specific group that I worked with recently, um, a lot of the female identifying young people come in with problems of self-esteem. So let's say that they have really low self-esteem and self-worth. There's a lot of bullying stories. I've noticed a lot of problems with eating. So that self-worth sort of trickles down into
Mm.
appearance, picking skin, disordered eating, a bad relationship with peers, and then just romantic relationships where they are being exploited
Mm.
because of that low self-worth. I think that's been a major theme so far. And these women have been very slow to open up. Maybe someone who looked like me, mom slash aunt slash grandma, has, I guess, perpetuated that intergenerational like violence, trauma, and silence with them. So that takes some time to even out. With a lot of young boys, I have noticed that they've been quicker to talk to me, to open up to me. And in fact, with time, I think they've slowly withdrawn and everything has become more boundaried slowly because they've realized that I'm not there to validate something
Yeah.
they're feeling that it's
Yeah.
not my job to
Yeah.
validate.
Yeah.
Um, and they've mostly come in for externalizing how they felt. So there's a very interesting and I think very beautiful relationship between anger and sadness. And I feel like young boys and girls so teeter towards the two ends of this.
Mm.
So for women, being sad is more acceptable than being angry. So they really internalize and become like really sad and depressed and nothing feels good and they don't want to do anything. And because it's so wrong for boys to be outwardly sad, men can't cry, especially these young South Asian men
Yeah.
who are born to immigrant families where the dads have, or they've noticed, or they've watched domestic violence their whole life, right? Where they've been chastised physically for wanting a hug, maybe sometimes, or expressing they've had a hard day. They just lose it. They get angry because that's more acceptable, right?
Correct.
I've had a young boy who was sent to me, for example, for he had hit his mom. He had hit his mother and it had become a big thing and social care got involved and everyone was like, oh my god, how can you do that? You're such a big buff boy and you have no time left in school. You're going to go off to college. Why did you do that? But I've seen over our sessions that it was just at the core of it was just that little boy who was like maybe 3 or 4 who went to his mom and cried and then she hit him first for years, right? um and she's the one who made him practice that when you're angry or when you're sad you need to be angry. So Yeah, I would say it's two ends of this. And the way I work with them really depends or ends up um, revealing which end they're at.
You mentioned earlier an example as an example, and you've actually contextualized all your points so beautifully because that really brings clarity to people who are listening, like us, who are not mental health professionals. You also had mentioned self harm. I was
Mm,
just wondering what is the system or mandate in the UK when something like that is mentioned to a mental health professional? Who all do you have to inform, if anyone?
mm. So, firstly, self-harm sounds really scary, but I think that a therapist would look at it very compassionately and in would try to understand what is the purpose it's trying to serve.
Hmm.
So there's some modalities in therapy and counseling that talk about this concept of something bad being there because it's protecting us from something that will be badder to
Right.
feel. I'm using the word bad because it might be easier to like understand. So
Sure.
maybe today, for example, I'm really focusing on my horrible relationship with a partner, and I'm just trying to like, hardwire, and I'm looking at it and I'm scrutinizing because, and everyone sees that, oh my God, you're being insane. What's wrong with you? You're just dwelling on it. But that's because it's maybe keeping me safe from having to process years of a dysfunctional relationship with my parents, right? So similarly here, self-harm is usually a way to externalize something that's going on inside. Um, I would say that I would check before informing anyone, right? In
Hmm.
the room, for example, if we did if we did this as so why don't you disclose self-harm to me? Just make up a scenario and just tell me what
So
you've
um, I have been. I want you to look at my arm, and there are lots of cuts, and I've been doing. I've been using my compass from my geometry box to do this for the past week.
the past week. And how did that feel?
Uh, Well, it makes me I feel quite numb generally, and at least when I do this, I feel like I'm there.
So you felt numb, as in you felt like nothing made sense and you felt like you needed to feel something.
I felt like I felt like I needed to feel that I was there.
Hmm. So you felt like a shadow before you did that.
Yeah, you could say that.
Hmm. Okay. So at this point, what I would do, I would go from here to be like, with my clients mostly, especially someone who has self-harmed before, I put them onto an app that helps them monitor what they felt at that time.
Mhm,
So they are already primed to notice what's happening when they are self-harming.
mhm, mhm,
So I would check in about this numbness that they felt. And I would make any connections from previous sessions to what numbness means to them.
mhm,
I would probably ask them at this point that, okay, so when you did this, where were you sitting? Um, did you tell anyone? Then I would maybe ask them, and what did you feel in your body? You were numb, but after you cut your hand, what did you feel in your body, and where did you feel it? What this does is allows you to recognize um, the emotion associated with the sensation, which which causes, I guess, better neural activity around self harm when you become more emotionally literate, I guess, which is a
mhm,
big
mhm,
goal of counseling. It lists out what are the main reasons, usually primary reasons, that young people might or anybody might self harm. One would be because
Is there
you're,
is there that kind of awareness though, you feel?
well, that's the kind of awareness that therapists, especially working with children and teenagers, try to raise. If I come in, if I get a referral and I already see the self-harm on it, then self-harm is something that I explicitly talk about in our
Mm,
contract.
mm,
That, hey, I know you do this. It's not a bad thing. It's keeping you safe from something worse.
mm,
And we'll work with it. And it becomes the one space where they don't feel ashamed of self,
mm.
because it's the shame that makes it so hard
Yeah,
within a school context.
so true.
You know, everyone looks at the scars, and then you are just suddenly some emo freak, someone who's just who wants attention, who's
Yeah,
attention
yeah, yeah,
seeking. These
yeah.
are all things that I discuss with my clients who
Mm,
are actively self-harming.
mm,
And within that room, I try to make it safe enough that they can say, today I just did it because I felt mad that my mom wasn't talking to me.
mm.
But it doesn't have to be that deep,
Yeah,
and it's okay. Everyone deserves attention.
that's
Um,
yeah, that's very helpful. Mm,
but yeah, so are you doing it to comfort yourself, to distract yourself, express yourself, find some kind of a release? So, like you said, you were feeling numb,
mm,
you needed a release,
mm,
and then just because you wanted to,
mm,
because it's a habit. Some people actually, you would say, who have certain conditions, maybe on the spectrum even, just do it because the sensation becomes a habit.
mm.
They're stimming. Yeah. So yes, so I would work with it in the room, and unless they were actively bleeding out in front of me, I wouldn't immediately pull a client out and take them to report it to someone. If it's fine, it's a scar, and I've asked them all the questions that I need legally. So I would ask them, when did you do it? What did you use? Do you still have the object? Does anyone know?
Mm,
Do you know how to, take care of yourself? Do you know about first aid? Can I take you to the nurse?
mm,
Beyond this, I don't really need to go into the
mm, mm.
whys and whats. I just need to focus on what's happening for them. Now, after the session, I'm mandated by law as a therapist here in the UK to bring it to a DSL, or
Mm.
designated safeguard lead,
Correct.
where they would, based on a school policy, usually either talk to the student directly, ask them if there's a safety plan that can be put in place, which is essentially having them reflect with you what's happened, who can you go to when you feel that way, give them signpost them to helplines they can use when they are not in school. This is just to ensure that when they're not in counseling, they're still safe.
Mm, mm,
And then it goes beyond that if it's really serious, and there's a referral made to something called a multi professional safeguarding hub.
mm,
There's like all these agencies, multi-agency safeguarding hub, which includes the NHS, children's service, mental health service, um, the council. If it's something to do with them not having housing, the
mm,
council gets
mm.
involved.
Correct,
So
correct.
it's just everyone comes together, but it
Sure.
starts with the therapist usually. Mm.
Okay, this can go on and on and on. Perhaps I will nag you a couple of months hence to do a part two, but we are
Mm.
already way over time and I can't afford you anymore. So, joking
Mm.
aside, you've been wonderful. I don't know personally what your long-term goals are, but I can tell you that there's most definitely an academic or a brilliant professor there as well. So
Mm.
thank you very, very much for making time, that too at the end of a work day. I really appreciate it. It's been wonderful interacting. I've learned a lot, and I'm certain those who listen will also have lots and lots to take away. So take care, keep doing the wonderful work that you're doing, and all the very best.
Thank you.